Can you hear me and see my screen?
Yes.
Yes.
Loud and clear.
Perfect. So I only have 7 minutes for my quick presentation, and so of course, being the speaker for the skin booster session a couple of months ago, I do realize that with the CyASIA workshops, webinars, it's always the roundtable discussion at the end that's most rewarding, and maybe a little less so the actual lectures themselves. So let me just go ahead and start. So just a quick introduction of myself. I'm a plastic surgeon from Hong Kong, and I graduated from medical school in year 2000, so still a long time ago. And I've been in private practice, mostly cosmetic practice, for the past 13 years. My clinic is called Central Health Medical Practice. It's in central part of Hong Kong. We're actually a multidisciplinary clinic, including myself, as well as GPs, ONGs, pediatrics, and other allied health as well. So to proceed with the lecture today, I want to first discuss this case of Miss C that I saw a few years ago.
Practicing currently in this Gemsil Doctors Dermatology clinic, right? Obviously it's from South Korea, right? So Jung, over to you, Jung.
Okay, thank you. Can you see my presentation?
Yes.
Okay.
You can.
Okay, I'm Kyu JUNG. I'm a board-certified dermatologist representing Jamsil Doctors Dermatology Clinic in Seoul, South Korea. Today, I'd like to talk about the side effects of PLLA, specifically on nodule and granuloma formation, and how to prevent and treat them. So what is a PLLA? PLLA is a collagen biostimulator. It can be used to create control and add natural volume. For example, in the lateral cheek, anteromedial cheek, nasolabial fold, Marianne line, temporal area. In addition, PLLA can improve skin laxity and wrinkle. And PLLA is different from filler. PLLA does not move after collagen synthesis. Over time within the tissue, the PLLA polymers break down through non-enzymatic hydrolysis to lactic acid monomers, which are then either metabolized to carbon dioxide and water or incorporated into glucose and natural eliminated from the body.
Okay. So speaking of the devil, here we have Alan Say. Yeah. Okay. My part is to give you some updated recommendations for managing nodules and granuloma related to Alan Say. I'm a dermatologist based in Taipei. All right, LNZ is composed of 70% of CMC gel and 30% of PCL microspheres. And for CMC gel, it acts as a carrier and carries the microsphere into the skin and also providing immediate feeling effect. So for the following few weeks, CMC gel is gradually degraded, and also PCL stimulates the growth of collagen. And generally, there are two phases for the collagen stimulation. For the first 2 weeks, it's acute phase that confines the microspheres or the product to our tissue, and then followed by gradual collagen stimulation. So,
well, actually, my method of treatment is always incision and drainage.
Mm-hmm.
I think that's the best way to correct the indurations.
Mm-hmm.
Because if you inject into the lesion, you don't know what's going to happen. So
Yes.
It's better to remove the foreign body or anything that causes the induration.
Mm-hmm.
I think that's the best method.
Yeah, I think we have 3 excellent plastic surgeons are on the panelists. So I think Stephanie, you will agree with that, right?
No, well, excision is not my first choice. Usually, I only excise when patients sort of give up, or they would rather just get rid of it and do not want to try the treatment with steroid. But generally, my first line of approach is saline and then steroid. and then steroid again if it's showing some sort of improvement.
And also Dr. Katia say hello to Daniel about the change or the change of the currently new HA, because most of the new HA are harder to be solved by hyaluronidase. So I would like to know your comment.
Okay, I was just writing the answer, but since you give me the chance, so first of all, thank you for the question. I do not mix hyalase with anything in order not to alter its action. I think this, not even lidocaine. I've stopped using lidocaine inside. Why? Because as the question says, in some cases, hyaluronic acid seems to be more resistant. So I don't want anything to interfere. And again, by using a cannula, I can make it almost painless, almost. The other trick is injecting very, very, very slowly. It's like a snail. Your thumb has to move like a snail, and then it doesn't hurt that much. What usually hurts is the pressure of the fluid, boom, going inside as a bomb. Number two, I only inject hyaluronidase after mapping the filler with ultrasound. This gives me 3 advantages. First advantage, if there's also some material that is not HA, it can be diagnosed. And so I do not expect it to be dissolved by hyaluronidase, so it doesn't look like a failure. People report that they have been injected with something, and then